I'm going to talk a little bit and comment on some of the new drugs that have been approved, which I think represent quite a challenge to an AML doctor treating this disease now. Some of the evidence, to my mind, is a little bit insecure, and some of these drugs, although approved, I don't think have reached their final destination of benefit. So we'll see what we think. Now, these are the drugs for someone who spent 30 years treating AML without a new drug. Life was relatively simple, but these are the drugs and dates of approval at the FDA which have happened to us, and I'm going to make some comments about this. Some are more encouraging than others. Some are based on randomized data that produce a survival benefit, others are not. So the first drug, as I mentioned earlier, is gemtuzumab ozogamicin, the first immunoconjugate antibody treatment in any cancer based on CD33 with a very potent payload of gemtuzumab ozogamicin, which cannot be given as an independent agent. It's much too toxic. The benefit of CD33 on the one hand is that when the antigen hits the antibody, or the antibody hits the antigen, the complex is rapidly internalized into the cell. So it makes quite a good delivery system. The controversy about it is that CD33 may not be the best target in AML, or it may be the best target. Certainly there's quite a body of opinion and data that suggests that it's not on the leukemic stem cell population, at least by conventional ways of calling a cell positive. But of course you may only require a few receptors to be there to allow this drug to hit the cell and be internalized. Now, this was the French Alpha Group study, which Pfizer chose as their approval study, and they added a fractionated dose, 3 milligrams per day on days 1, 4, and 7 of course 1. They also gave the drug in the consolidation phase at 6 milligrams a day. This fractionated scheduling was based on the fact that if you give Myeloid to a cell in vitro and it survives at all, it will re-express CD33. So this was the idea of repetitive treatment being more effective. What this study did not answer is whether you need the drug in the consolidation or whether the benefit that you see from it is entirely due to induction. So this was the schedule, and that was the event-free survival benefit, which came out in their first publication, which was significant. The OS at that point turned out not to be significant at that time. The power was limited because it was only 250 odd patients. It was intermediate and poor risk. In other words, there were only a handful of CBF leukemias involved in that trial. Subsequent follow-up of this study also fails to show an overall survival benefit because many of these patients were rescued and given gemtuzumab late and given transplant and rescued. So the trial never actually technically came to give a survival benefit. And this was the preliminary analysis. You can see a fairly large event-free survival in the left-hand panel. The OS top right was not significant. We, in the meantime, had been looking at large numbers of patients giving one dose in induction of 3 milligrams day 1, as did the SWOG 106 study, gave 6 milligrams on day 4, trying to avoid giving it with daunorubicin. That was the study that was proposed to the FDA as their approval study, and it failed. The other studies all showed benefit. So we decided that the best thing to do was to do a patient-based, individual-based meta-analysis of these 5 trials, which followed a similar strategy of augmenting induction chemotherapy with gemtuzumab. They weren't identical in doses and schedule, but they had a similar theme, and you can see that their are something like 3,500 patients in this meta-analysis. And each individual was updated. It wasn't just taking the original publication date. Patients were followed and the latest update was included. And what you see in the left-hand panel is the effect of core binding factor leukemia. Mostly these patients were derived from the MRC study or the SWOG 106 study. And as I say, relatively few patients were included in the alpha study. On the right-hand side, you see the intermediate risk. This is not a large difference, but it is a significant benefit of survival. And what is universal in all the studies is that so-called high-risk patients, judged by cytogenetics, do not benefit. So if you were going to use this and you wanted to save money, you would want to know who your poor risk patients were and not give it. It doesn't do the patients any harm, it just doesn't do them any good. And we took the view that it would be too difficult in 180 hospitals to get the cytogenetics for the first course of chemotherapy, so these patients got the drug anyway, even although the meta-analysis had not shown any benefit. But the approval came based on largely the meta-analysis and principally the French alpha study, and this was it. Notice that it says here that patients must express CD33. Our trial did not exclude CD33 patients, and we weren't able to demonstrate that people who did not express CD33 did not benefit. So my personal view is I don't think CD33 status matters that much. Question is, are there any prognostic factors that help you decide within this who benefits? The other, as what I mentioned earlier on, this impact perhaps on who you would transplant and who you wouldn't transplant, and I showed this slide earlier on with the red line showing the intermediate risk from diagnosis sitting at 64%. And this suggests to me that if you use Myeloid, there's no additional benefit in giving a transplant to these patients. So there are remaining issues. Is there any value indeed in giving it in consolidation? There's precious little data to answer that question. What dose? We think 3 milligrams is the best dose, but what schedule? Do you need to give it 3 times? Is that the best schedule? Is 1 just as good as 3? Is 2 as good as 3? And the current trial run by Nigel Russell in the UK has looked at 1 versus 2 doses of gemtuzumab on day 1 and 4. And I'm told, although it's not totally analysed, that 2 doses might be better. And they're going ahead to look at, they're now going ahead to look at 3 doses versus 2 doses. Does it have to be given in course 1? Clearly there are logistic difficulties, particularly if you're after CBFs, to know the status of the patient. So we have a certain amount of experience of not giving it in course 1, but waiting till course 2, which I'll show you. And of course, are there any predictive biomarkers that suggest that these patients are particularly going to benefit? And is MRD measurement of any help, as has previously been discussed? This was our AML 15 study that had a 2-by-2 randomization. They got an induction or not. They were re-randomized in consolidation to get it or not. And you can see that giving it in consolidation made no difference. And that didn't matter whether they got it in induction or not. Giving it in consolidation, course 3, did not help. Now we come to this issue of dose. This was the meta-analysis suggested 3 was effective as 6, but there were early deaths or more toxicity. And the bottom line show our randomized study looking at 3 milligrams versus 6 milligrams, showing basically no difference. As to the issue of giving it in course 1 versus course 2, here are core binding factor leukemia patients in the black line who got it automatically on day 1, course 1, compared with patients who got it on day 1, course 2. In other words, people waited to confirm that they were core binding factor leukemias. And you can see that it's slightly inferior. In this particular analysis, not significant. We haven't updated this to see whether the gap widens, but my own feeling is that it's better to try and get the core binding factor definition morphologically or FISH analysis as quickly as possible. The other trendy thing is looking at SNP, CD30 SNPs, and this was done by the Children's Oncology Group, looking at the pediatric experience, which I may say is very similar to the results produced in adults. And you can see that for the CC polymorphism shown on the left, there was a reduction in relapse, but not in the other polymorphisms. So our molecular guys got onto this and looked at our data, which is shown here, and we can see no evidence of the polymorphism having an impact. So this is a controversial issue. Both were good, large studies, but showed completely different results. So the explanation of this discrepancy is not yet clear. Now we move to FLT3 inhibition. There have been a number of these over the years. The first two were the first generation, what we call dirty TKIs. They hit multiple targets, but included FLT3. Sorafenib you've heard about. Quizartinib, ponatinib, crenolinib, gilteritinib are all second generation, which are much more targeted, at least when you look at a kinome map. And here are kinome maps showing on the left the CEP701, listortinib, the midostaurin, and then sorafenib and quizartinib, which is more selective. It's not clear whether you'd be better off to have one that hit a number of targets or a very specific one. You may derive some unexpected benefit in a multi-kinase approach, but on the other hand, you may get more toxicity. We did a 500 randomized patient trial looking at listortinib combining with conventional chemotherapy as part of the AML 15 and 17 trials, and we could show no difference in adding that particular TKI to chemotherapy. There was one caveat. The pharmaceutical companies involved at the time did not allow you to give azole antifungals to these patients because it increased the toxicity. There was a pharmacological effect due to P450 induction, etc., that they said, no, you don't use antifungals. Our response, well, if you can't use antifungals, you virtually can't use the drug in AML. So we allowed our investigators to use antifungals with provision that they could reduce the FLT3 inhibitor dose. And in our publication of that trial, we show that if they got antifungals plus the listortinib, they had a significant survival advantage. And this suggests that there may be pharmacological issues in relation to these drugs and their persistence in the circulation that we've not adequately addressed. So there may be still issues about optimizing these otherwise active drugs. So this is the famous RATIFY study. You've seen this going through. It just merely added the midostaurin to conventional chemotherapy, both in induction and consolidation and maintenance, although relatively few patients got the maintenance midostaurin for various reasons. Either they weren't around or they had earlier toxicity. Notice people often talk about combining it with chemotherapy. Notice this does not mean adding it to chemotherapy. It's sequential treatment. This is quite important because in the development of coming up with the combined treatment, adding it on the same day as the chemotherapy was found to be fairly toxic. Nevertheless, it produced the benefit, as you see here, some sort of benefit. I don't think it's dramatic. It's not the end of the story, but it is a help. As was pointed out earlier, you see in the right that the various levels of ITD and allelic ratios, it seems to benefit them all. And on the right-hand side, you can see that benefit translates into patients who also receive transplantation. Now, there was a study, a subsequent study, looking at the RATIFY data as to whether maintenance made any difference, and the net result was they could show no survival benefit in receiving maintenance compared with those who got it versus those who did not get it. So, as it stands, no benefit in maintenance. So this was the approval, and interestingly enough, which can cause people problems, it's approved in the context of giving it with 3+7 chemotherapy and using an approved test, FDA-approved test for demonstrating the FLT3 mutation. That can be a little bit of a problem. We found in the UK, when asked if we could get the drug for our trial, they said, but it's only approved with 3+7, that's not what you guys are using. But we got round that, but again, the wording was maybe too specific. This is the slide that I mentioned earlier on, where the 90 milligram versus 60 randomization showed a suggestion that 90 milligrams helps the patients with FLT3, and there's the data, which was updated. It's 200 patients in that randomization. So it may be that giving 90 milligrams in your chemo, if you've got a FLT3 patient, is a good idea. Maybe, and indeed we are asking that question, does 90 milligrams plus midostaurin help do better than not? So that's one of the questions that remains. Now we've got the second generation. I'm going to talk about quizartinib separately. It's been around for a long time. It's been sort of mismanaged by the companies who submitted it something like 6 years ago to the FDA with an unrandomized trial, and were told to go away and do a randomized trial, which is ironic given the recent approval of gilteritinib. Cronologib is an interesting drug out there, and they are going for phase 3 trial upfront combined with chemotherapy. And gilteritinib was approved a month ago as another second generation FLT3 inhibitor that can be useful based on an unrandomized interim analysis of a study called Admiral, which was a developmental study. This is the quizartinib anyway, treating relapsed refractory FLT3s with this drug as monotherapy, and you see in the right-hand panel that the combined response rate was around about 50%. Very few of these were complete remissions. This is a characteristic of some of the FLT3 inhibitors given in relapse. They clear the marrow, but you don't get full hematological recovery. And the FDA took a dim view of claiming that CRP or CRI was a clinical benefit at that time. I think Donald Trump has taught them other rules. Now we come to gilteritinib, thought by experts like Mark Levis to be a better drug in general terms. Again, this is active. Particularly interesting is the D835, which is a mutation that causes resistance to the other FLT3 inhibitors. So it's active in that situation, which makes it attractive. The dose-finding study says it's 120 milligrams. The Admiral study, from which the approval is not completed and it's not published, this was a median age of 60. You'll see that the CRI rate was not that impressive at 21%, yet it got approved. And one of the benefits was that 30% of the patients who were transfusion dependent became independent. So we still have to wait to see how good that Admiral study really is, but the drug got approved. And there it is, November 2018. There's a rationale, of course, and to be fair, the studies are planned or are beginning to add the drug in other situations. And this is the phase 1 data looking at adding it to conventional chemotherapy. This is much like the RATIFY trial, including a maintenance component. And so that study is ongoing. And And this is interesting. The data that was already known about that phase 1-2 study is that the remission rate in the FLT3 patients was very high. It was over 90%. And 120 milligrams is clearly able to be given with intensive chemo. This shows you in the left-hand panel the mutant FLT3s in that study, where the overall response rate was 100%. We're only talking 21 patients at this stage. So it looks interesting. And these are the studies going ahead with this drug. They'll finish the ADMIRAL trial. They'll look at maintenance after consolidation in patients who are FLT3. That'll be a randomized maintenance trial. That'll take many years to accumulate. Then the MORPHO trial, which is a randomization after FLT3 transplanted. And the LANSWING, which goes for this older population using azacitidine or decitabine plus or minus gilteritinib for FLT3 older patients. FLT3 in older patients is not as common. It happens in about 12-15% of older patients. Now we come to the IDH1, IDH2. These genes were found to be important mutants in the whole genome sequencing study. They came out and they represented potential targets because they interfere with the chemistry that induces, that delayed and blocks differentiation, much the same way as the 1517 interrupts retinoid-induced differentiation. This is a differentiation blocker. These mutations occur in overall AML about 8 to 10% of patients, a little more common in older patients. They're associated with other features you can see here. And this is the mechanism that are isoforms. The isoforms, by and large, don't make much difference to the responsiveness to these inhibitors. So these are the two inhibitors, ivosidenib and enasidenib for the 1 and 2 respectively. And interestingly enough, here is the monotherapy just given to these patients with relapsed disease, getting a 30% remission rate by and large. This is quite impressive. This does not happen instantly. It may take 2 or 3 months before remission is achieved. And even if remission has not been documented, the patient still remains stable, which was an unusual feature. And it wasn't known at that point, but the explanation for this is that these are causing slow differentiation of the clone. And indeed, about 10% of the patients on these drugs can get a differentiation syndrome equivalent to what you see with ATRA. So this is the relapse refractory, just looking at the IDH2 inhibitor. Again, you can see the CR 20%, the CR/CRP is another 8%. So quite useful. And the survival, just given modern, this is for relapsed patients, you can see that the median survival is about 9 months. It's clearly better in the red line in the bottom graph for patients who got their CR. So these drugs are quite useful. Nobody knew what the outcome of IDH1, IDH2 was with standard chemotherapy, so we looked at this. And this looks at the cumulative incidence of relapse with these 2 mutations. This is in first round of treatment, first remission. And you can see that this looks very similar to any other AML. They're not particularly high risk in terms of likelihood of relapse. So if you're wanting to do a relapse study, you start with 1,000 new patients. 100 of them will have these mutations. Half of them never relapse in the first place, so you'll get 5 patients out of your 1,000, or 50 patients out of your 1,000 for your trial. This is the IDH, just with chemotherapy, looking at the survival. And you can see on the right-hand side, the red line looks at the older patients where this mutation is slightly more common. and the younger patients, this is post-relapse. So these, if you imagine these curves going together, that doesn't look tremendously superior or inferior to what you're seeing with the drug alone. So the obvious question for us clinically is what happens if you combine the two? And this was the approval. Again, it's tied to, which troubles the US guys, they have to use this companion diagnostic that was approved, and this was approved 5 or 6 months ago. This is the ivosidenib, we can skip that, I think. Again, this shows a very similar sort of survival curve that you see relating to responders or not responders that you saw with the other drug. This is the chemo, and here on the right-hand side, you see they do a little less well. There's not so much age discrimination. The red line is the over 60s, etc. So these curves with monotherapy look as good as we can achieve with the chemotherapy, and this is the approval, July 2018. So again, this study, as is obvious, is going forward. This is, however, in untreated patients who are IDH1 or 2 positive, giving these drugs 120 milligrams a day probably is going to be the dose. And this is the obvious combination. So this will put pressure on you to require you to know whether these patients have got these mutations as soon as the patient's diagnosed. Now we come to a surprise. The SMO, the Hedgehog signaling inhibition, glastinogib, if that's how you pronounce it. There have been a number of SMO inhibitors around. Some have been too toxic to combine with chemotherapy, and Jorge Cortes kindly lent me his slide. This shows the mechanism. This drug is interfering with the microenvironment of the leukemic cells, making them potentially more susceptible to chemotherapy. This is an interesting strategy. Other drugs do that as well. It's yet to be shown whether that strategy really can produce clinical benefit. So this is the study, the Pfizer study, looking at an unfit population on the upper half and a fit population. And the phase 1 develops the combination with low-dose Ara-C or in the fit with the conventional chemotherapy, induction and consolidation. And then this led to the phase 2 randomized trial, which was the basis of its approval, comparing low-dose Ara-C 20 milligrams twice a day for 10 days, plus or minus ganatestrib. Glacitinib. And this is the CR/CRI on the combination here, showing 23% of 83 patients got a CR/CRI, compared with 5%. This is my first problem. In the UK, where we used low-dose Ara-C, we saw, when we first published on it, 18% remission rate. But you can see as high as 28% remission rate, and we see that as well. So to see such a low low-dose Ara-C remission rate is a bit worrying. Whether it's just chance, I don't know. But the curve of difference looks okay. Actually, looking at the yellow line, that's more or less what we would expect to see with a low-dose Ara-C population. So my reservations about the low remission rate in this study may not need to be worried too much about. They did an historical comparison on the left-hand side. This looks at the various subgroups. This is an intensive chemotherapy pilot looking at combo with 3+7, CR rate 46%, overall 54%, looking at the different risk groups. Then they looked at the 3+7 combo data against historical control, I think German patients, and they showed a perceived advantage using against intermediate 1, intermediate 2, 15 versus 9.5, 13, 9.2, 8.5. versus 4.8. This may or may not be true, but historical comparisons of this nature are really quite dangerous statistically. I make the point about the low-dose RSC here. You can see that the top line, these are individual studies where the control arm was low-dose RSC, and this just looks at the control arm. You can see that the first study, AML 14, was 8%, but subsequently we get 19, 22, 19, 25, 29, 29, 18. So the remission rate varies quite a lot, and this may reflect the fact that in old patients, depending on your entry criteria, you may have quite different patients in your study if you set say a cardiac limitation on entering a particular study. Much more pronounced than I think in younger patients. So this just shows you the SMO inhibitor strategy as you would expect. They're approaching it combination with 7+3, and in the low dose situation, combination with azacitidine, which is more popular than low dose RSC. So that's the future for that. And this was the approval a month ago, approved with low dose RSC. Again, this was an interim early analysis. The next one is BCL2, venetoclax, which you'll know from CLL. BCL2 is an adverse prognostic factor in AML, long been known. Its expression level increases with age of the patient as well. And so it's an obvious target in AML. However, giving it as monotherapy shown in this study showed that you get a very modest overall response rate with monotherapy. And the MD Anderson and Andrew Wee in Melbourne started looking, this is just the mechanism, started looking at the drug in combination, and this was Andrew Wee's data looking for a dose that you could add to low-dose RSC, the right low-dose RSC schedule, and ended up with 400 milligrams actually. They took this into the combination, and you'll see that the complete response rate or overall response rate was something of the order of 55%. Now you're talking, because low-dose RSC at best was under 30%. Now you're talking a combo that delivers 50 to 60% response rate. So this looks hopeful. And in addition, this appeared to be durable. This is unlike a low-dose RSC alone curve. These patients seem to have stability with the venetoclax. So this is causing quite a lot of excitement. Everybody wants to use that in every imaginable AML situation. And Andrew and Dinardo from the MD Anderson put together their scheduling of venetoclax with low-dose RSC or either azacitidine, decitabine, obviously targeting this older population. And again, this looks at the demethylating agents, a very similar looking outcome, again showing if they get a response, the median survival at 2 years has not been reached. So this is a game changer, I think, in AML therapy for the older patient. And this is the randomized study that's going ahead. And again, this is looking at the azacitidine-decitabine combination alone. And again, this is showing something of the order of 70% overall response rate. And this looks at subgroups by molecular on the bottom or cytogenetic risk. And you can see even in the poor risk cytogenetics, the combination is hitting, in the case of AZA, 67% response, or decitabine 80% response. Very impressive. So these are the conclusions, that you're getting around about a 70% overall response rate. The basic genotype, etc., doesn't really matter in terms of response. The response appeared to be pretty durable at the present time, and the phase 3 trial is going to give the definitive answer. This is certainly something to consider for AML. And of course, people are considering what would be useful to add to venetoclax as well as chemotherapy. And here are all the things that are going ahead in relation to venetoclax plus in the treatment of AML. And this was its approval again last month. There must be a lot of drink around in the FDA for celebrating all these drugs, I think. The final drug that's been approved is this called venetoclax, formerly CBF-T51. This is a bilaminar drug that incorporates daunorubicin ara-C in a fixed ratio. Anyone who does in vitro testing of drugs knows that if you do combinations and you change the ratio in the test tube, you get different sensitivity. And this was based on showing that 5-to-1 ratio is the one to capture. So this, putting it in a liposome, ensures delivery of that ratio to a patient. You couldn't do it any other way. So some of us are a bit cynical as to whether this was actually going to make any difference. There is a rationale also in the membrane of the liposome that it gets into the marrow preferentially. And so there's a wee bit more to it than just wrapping it up in a liposome and sticking it in the patient. And this was the study. This is a randomized study selecting patients who emerged from a phase 2 experience showing that if they had secondary AML or a history of MDS, they were the patients who seemed to benefit most in the phase 2. So they were taken into this phase 3 trial, 300 odd patients, randomized, conventional 3+7 versus the liposome. And this was the outcome. Clear significant benefit for the liposomal treatment. Now, the criticism that came out in Europe, and Europe investigators were, well, wait a minute, if we have patients with this sort of background, secondary MDS, to MDS, etc., I'm not sure we would use 3+7. Maybe we would use FLAG-IDA. So there has been a certain amount of doubt about that control arm. But I think, to be fair, this is a drug that needs consideration. In the UK, this is being looked at in high-risk patients versus FLAG-IDA to try and get at that issue. Was the control arm of this study really good enough? And this was its approval in August 2017. So we've been bombarded with a number of drugs that certainly do things in AML. In 2 of these cases, this was based on randomized data that produced a survival benefit. In others, it's kind of given us the opportunity to look at this drug, but it's difficult when the drug is so expensive. But clearly, if these other drugs are to fulfill their potential, they need to go first line, probably on the back of a course of standard chemotherapy. Thank you very much.
Thank you, Prof. Burnett.